Okay, we'll make a start. Good morning, everyone. I hope you're all well, and thanks for joining us this morning. I realise we're currently living in unusual times, and on behalf of the National Evaluation Team, our thoughts are with our colleagues and those working within the sector to keep the most vulnerable in society safe at the moment. Given the current climate, it is great to have so many of you join us this morning. The webinar forms part of the National Evaluation and Learning Programme for the National Lottery Community Fund's Fulfilling Lives programme. And this morning's webinar will focus on improving access to mental health supports for people experiencing multiple disadvantage. There will be 3 presentations, each lasting around 15 minutes, and the format is designed to allow opportunities for you to ask questions as well. I'll introduce the speakers in a moment, but first I'd like to go over just a few technical aspects that everyone is comfortable with the WebEx platform. So firstly, you'll notice that all your microphones are currently muted. This is just to make sure we get good sound quality during the presentations, and we also ask that you turn off your webcams during the webinar. So once we get to the discussion section, if you indicate that you want to make a comment or ask a question, you can unmute your microphones then to ask it in person. On the lower right-hand side of your screen, you should be able to see a chat box function just at the bottom there. So if you'd like to ask a question of the presenters, please type them in as we go, and I'll come to you after the speakers have finished. I do encourage that you join in and ask the questions in person if you can, as it makes for a much interesting session and is a friendlier experience for our speakers. But if you aren't able to do that, please do just type your question in and I can ask it on your behalf. And if you're struggling to read any of the slides today, then you may wish to use the full screen mode, so you can do that by clicking on the 2 diagonal arrows. The webinar will be recorded as well and uploaded to the Fulfilling Lives National Evaluation website after today, so should you wish to revisit any of the content or share it with others, it will be available. So I'd like to thank our speakers for joining us today and making this learning opportunity possible. To start us off this morning, we'll hear from Rachel Moore-Eaton, Associate Director at CFE Research, who will be sharing insight from the National Evaluation of Fulfilling Lives. Following Rachel, we'll hear from Mark Crowe. Mark is Evaluation and Learning Lead from West Yorkshire Finding Independence. Mark will be talking about how they developed in-house mental health assessment and cognitive behavioural therapy services, which were tailored to the needs of people experiencing multiple disadvantage. And then last but not least, we'll be hearing from Andy Meakin, Programme Manager of Voices at Stoke-on-Trent, and Bruno Ornelas, Head of Service Delivery and Safeguarding at Voices. And Andy and Bruno are going to co-present, and they're going to be talking about the Care Act toolkit which they developed. So with no further ado, I will hand over to Rachel now and unmute you. Oh, Rachel's just disappeared from our list. Aha. Rachel, are you there?
I'm here. Thanks very much.
Brilliant. Over to you.
Thanks. Good morning, everyone. Thank you for joining us. Just like to reiterate what Beth said there. We really appreciate you taking the time out at this current time to listen to this webinar. I'm going to start by giving an overview of findings from a recent study that CFE Research and the University of Sheffield undertook as part of our evaluation of the Fulfilling Lives programme. It's quite a detailed report, so I am going to just highlight some sort of key findings, but hopefully that will help to set the scene for the following presenters. I've gone the wrong way. Here we are. So Fulfilling Lives is a major strategic investment by the National Lottery Community Fund. They have invested £112 million over 8 years to support people affected by multiple disadvantage. And I'm going to say a little bit more about what that means shortly. So we're now 6 years into that 8-year investment with a couple more years to go. And the programme aims to change lives of the individual beneficiaries affected by multiple disadvantage, but also to change the wider systems of support so that there is a lasting legacy. And importantly, a key strand is to involve beneficiaries themselves throughout that process. The programme supports 12 voluntary sector-led partnerships. They're based in a variety of locations across England, from seaside towns to major cities, London boroughs, and in the case of West Yorkshire, large and diverse sub-regions. And we'll be hearing, as Beth said, from 2 of those partnerships in today's webinar. I said I would say a little bit more about what we mean by multiple disadvantage as well, because I'm conscious this can mean different things in different contexts. So for the purposes of the Fulfilling Lives programme, multiple disadvantage means experience of 2 or more of homelessness, alcohol and substance misuse or substance misuse, reoffending, and mental ill health. But beneficiaries also experience a range of other forms of disadvantage, including domestic abuse, long-term health conditions, and other disabilities. And the programme really aimed to support those with the most complex needs who were not otherwise receiving help from services. And if we just have a look at some of the data that we've collected about beneficiaries, I think we can see that the programme is successfully doing just that. So looking at the number of those defining needs that people on the programme experience, we can see that over half are affected by at least, or most are affected by at least 3 of those needs, and over half are affected by all 4. And experience of mental ill health is particularly prevalent. So I think about 93% of beneficiaries have some form of mental health problem. And analysing the programme data, we find that getting help with mental health problems, and in particular counselling and psychological therapies, are associated with people making better progress. So in terms of their well-being, their self-reliance, and reducing risky behaviour. We can't say for definite that it's sort of counselling and psychological therapies that are causing that improvement in progress, but there's a clear statistical association between those 2 things. But we can also see actually that very few beneficiaries are receiving that type of support. So when people first join the programme, on their first 3 months on the programme, which we use as a baseline, only 17% of beneficiaries received counselling or therapy. And although we can see that there is some increase in use of that particular support over time, all partnerships reported difficulties to us in accessing appropriate mental health support for their beneficiaries and identified that as a strategic priority for change. So this really was the spur for doing a bit more of an in-depth study around access to mental health services. So earlier this year, we published a report exploring access to mental health services and support for people affected by multiple disadvantage. In that, we look at barriers faced by people accessing services and how Fulfilling Lives partnerships have responded to those challenges. We've drawn on evidence from a wide range of sources, so including a review of local evaluations carried out by partnerships themselves, analysis of quantitative beneficiary data, as I just mentioned. We carried out focus groups with frontline staff, held a series of in-depth conversations with partnership leaders, and then carried out visits to 5 selected case study partnerships, where we spoke to staff, current and former beneficiaries, and representatives of partner and stakeholder organisations, so mental health services, police, social care providers, etc. The full report, a summary version, and those 5 case studies are available from the evaluation website, and I'll provide the address at the end of the presentation. So just to sort of cover some of the key findings from that report, I think we had identified 3 broad types of barrier really. The first was just actually getting access to mental health care and support was extremely difficult for many people in this group. The mental health system is seen as complex and difficult to navigate, even for support staff, never mind about the beneficiaries that are trying to navigate their way through it. The key point of access to secondary mental health support and treatment is often via GPs, but we also know that people who have no fixed address sometimes find it difficult to register with a practice. A lack of understanding of multiple disadvantage was said to often lead to stigma and discrimination, but by far the biggest barrier I think that we found was the presence of co-occurring substance misuse. There's a particular overlap between mental health and substance misuse. 90% of our beneficiaries are affected by both. And we also know from the wider literature there's a strong association between experience of complex trauma and multiple disadvantage. So we see people self-medicating mental health problems by using substances and then finding themselves in the catch-22 situation where they're unable to get help with their mental health without addressing their substance misuse first, but they can't address their substance misuse without help for their mental health problems. If people are able to access the system and some form of support, the form that often takes, we also found, was often inappropriate for people experiencing multiple disadvantage. So not only do services sometimes struggle to handle just the number and the complexity of issues that people present with, traditional appointment models don't work for many in this group. So the sort of examples we found included use of inappropriate communication methods, such as posting out appointments to people with no fixed address, or insisting on telephone calls, which are unsuitable for many. People often find them sort of quite stressful. Then appointments taking place in institutional and clinical settings that often feel really daunting to beneficiaries. And negative past experiences can create a lack of trust in the healthcare system. So long waits for assessment or treatment can lead to people just feeling disengaged. And as a result, failure to attend appointments then can often lead to people having their cases closed, and you need to be re-referred, and then people find themselves back at the beginning of a long and often frustrating journey. And the third sort of broad area of challenge I think we found was that actually some of those barriers are perhaps unsurprising when we consider that people with lived experience of multiple disadvantage are rarely involved in the design, not just of mental health services, but the wider system of policies and strategies that influence how that system works. We found a lack of specialist services to support this group, and a gap through which people with experience of multiple disadvantage often fell. So limited resource means, and high demand for support and services means that thresholds for accessing mental health care are increasingly rising, and such that people often don't meet the eligibility criteria for that. But equally, the needs of this group are often too complex for services such as IAPT that are designed to tackle more common mental health problems. We wanted to particularly focus on the different ways in which partnerships have responded to and addressed some of those challenges. And again, we identified a number of sort of broad areas. The first is helping people to access services and support, often in the form of navigators, or staff often have similar roles with different job titles, where they take time to build trusting relationships with beneficiaries and advocate on their behalf, and really work really hard to get people into services and access the support that they so desperately need. To do this effectively, the navigators need up-to-date knowledge about people's legal rights and entitlements, as well as a good understanding of how different parts of the system work, how to make referrals effectively, who the key contacts are, what the different referral pathways are. And we'll hear shortly from voices about one of the ways in which they've helped to achieve that. I think also key is people having small caseloads, so we're talking 7 to 10 clients generally, which allows staff to build those trusting relationships and spend extended periods of time supporting people. We also saw many instances where the system seemed to be working better. It was often down to good personal relationships between professionals. People talked about particular professionals or staff members who, quote, got it. And I guess we've seen how Fulfilling Lives have worked to formalise those sort of relationships and make them more likely to happen by providing opportunities for different sectors, different groups of professionals to come together through things like communities of practice, multi-agency training sessions, and just co-locating professionals And those types of initiatives can help professionals to understand the pressures, the challenges and the limitations of each other's work and begin to work more collaboratively. So pushing at the edges of the system to get people in, as the navigators do, it is one approach, but it's only going to take you so far. And another way that Fulfilling Lives Partnerships have sought to address some of the issues I talked about is to model what a more appropriate service for people affected by multiple disadvantage might look like. So that's through commissioning their own specialist in-house services. And two of our case studies, Opportunity Nottingham and Wi-Fi, who you're going to hear from shortly, fall into that category. And their work has generated lots of learning about how services can be created in a way that's more person-centred and flexible. For example, embedding therapeutic staff within a wider navigation support team so that people can get support with mental health, but also it's a holistic programme of support that addresses other issues such as accommodation, benefits, physical health, etc. And one of the key themes that we found that occurred time and time again was the importance of both trauma-informed and psychologically informed approaches. So, as this quote illustrates, having some kind of psychological framework can be really helpful to help practitioners understand why someone might be behaving in a particular way, what kinds of services are going to be more appropriate, and how to modify approaches and be reflective of how to redesign support and services so they engage people more effectively. And finally, we saw examples of Fulfilling Lives Partnerships working to support people with lived experience to become involved in the co-production of services and strategies. So one of our case studies of Golden Key in Bristol looks at how people with lived experience have been involved in developing local mental health strategy. Similarly, another of the case studies looks at training for blue light responders to mental health crises in the northeast. And that was something that was developed and delivered collaboratively with people with lived experience. And that was seen as like the crucial ingredient for success of the training, and ensured that the scenarios that trainees were presented with were really authentic. One of the key factors of involving people with lived experience in co-producing strategies and services is that people have sufficiently recent experience of mental health services for their insights to be relevant. Having said that, we acknowledge that that can be challenging and that people do need lots of support. But I think the Golden Key case study in particular shows that that can be achieved with the right resources, the right will, basically, and the right support, that meaningful involvement of people affected by multiple disadvantage in those kinds of activities is possible. So I'm going to finish there. Hopefully that's given you just an overview of some of the themes and content of our reports that we published earlier this year and the case studies, and has whetted your appetite to find out more. So as I mentioned, the full report and a summary version along with the 5 case studies are on the evaluation website. The address is on the screen now. We'd also encourage you, and I'm sure Beth will say this at the end as well, but we'd encourage you to sign up to our quarterly newsletter so you can keep up to date with what's happening on the Fulfilling Lives programme. And yeah, I'll take some questions now, but equally, if you want to drop me a line afterwards to follow up on anything, then please do. My email address is there as well. Thank you very much.
Brilliant, thank you, Rachel. It's great to get an overview of the kind of piece of work as a whole, especially with the presentations to follow. So if anyone has got any questions, please do pop them either in the chat box function at the bottom right-hand corner, or please do unmute your microphones yourself to ask them. In case, just whilst we're waiting, Rachel, I wondered if you could give us some more, kind of any detail of any upcoming work that's happening for the national evaluation?
Sure. So we've been working on a couple of other sort of detailed investigations of particular aspects of the work of Fulfilling Lives. One is looking at workforce development issues, so that incorporates both supporting people with experience of multiple disadvantage to move into or closer to the labour market, but also the support needs for the wider workforce to equip them to support people affected by multiple disadvantage effectively. And related to that, we've also been looking at the role people with lived experience can play in creating the sort of systems change that the partnerships are seeking to achieve. We did a reasonable amount of work on those before the current crisis really sort of took over. And so we're hoping to be able to continue to work on those in the background without bothering the partnerships too much at the moment. And yeah, fingers crossed we'll be able to have some findings to report later in the year.
Well, we'll keep our eyes peeled. Thank you. Oh, something's just come through. Susie, if you don't mind, I'm going to unmute you. Hopefully it's worked, and you can ask your kind of question or comment in person.
Hello, everyone.
Hi.
Do I need to click it on my...
Hi, we can hear you.
Oh, brilliant. Thank you. I wasn't sure I needed to unmute as well on my side. Thank you so much for that. So I'm a research manager at Groundswell, and we're going to be working with MPC and Creder, Sheffield Hallam. And we're going to be working on the Fulfilling Lives evaluation Lambert Substance Solution. But obviously your point about the GP access, which is increasingly a problem, but we've actually got some cards. I don't know if anybody's seen them, but you can email us on info@groundswell.org.uk where you can order some cards. If anybody needs any cards to help people register who don't have a fixed address, you can there. And we also have our Health Now team are rolling out our peer advocacy across the UK in Birmingham, Manchester and Newcastle.
Well, thanks, Susie. That's really helpful to know, and I'll definitely get in touch because we might be able to share those resources when we share the slides from today as well.
Brilliant, thank you.
Well, thank you. So, with no further ado, looking at the time, I'm going to hand over to Mark. Bear with me, Mark. I'll just hand you control of the presentation and unmute your microphone. So now I'd like to hand over to Mark from West Yorkshire Finding Independence, and Mark's going to be talking around kind of the mental health services that they've developed in at Wi-Fi. So over to you, Mark.
And thank you, Rachel, for your presentation. I think what I'm going to describe will be a bit of a kind of a microcosm and in local context, really, of the things that Rachel has kind of discussed and described. So I'll just get straight into it, really. And I've overshot already. Okay, so Wi-Fi, as Rachel said, Wi-Fi works across all of West Yorkshire, which is Bradford, Calderdale, Kirklees, Leeds and Wakefield. That's 3 of the 10 largest cities in England are included in that group of 5, but there's also some really large and very dispersed rural populations in there, and some of that will become evident later about that issue. We've worked with 823 adults over the 6 years of the project, and actually a lot of the other projects carry on for another 2 years. West Yorkshire's winding down now because our programme was only ever going to be a 6-year programme. As it first, like I said, I'm the research and evaluation lead, but I didn't just want to be the guy that went around hounding people for data. I also managed to squeeze into my original job description that I'd look after 2 other things, which were 2 funding schemes. One is a personalisation fund, which is small amounts of money for people to do things that will help them progress in their support plan. And the other is the what we call a co-production and innovation fund, which is how we funded this the piece of what I'm going to describe later on, which was for people with lived experience and professionals in districts to identify a gap in services and work together to try and produce a solution. And so as I talk through, you'll see that access to mental health services in this particular district was a very significant issue for people, and that's how we came to develop the piece of work that I'll talk about in a minute or two. One of the things about access to mental health services, well, access to services in general, is that equality of access relies on a kind of equality of supply. And one of the things about mental health services is that they're not equally distributed across the whole of England. There are twice as many psychiatrists practicing per 100,000 people in London than there are in Yorkshire and the Humber. So already there's a straightforward challenge in people being able to access services from a supply side point of view. The other thing is about where those services are located. And in a district like Calderdale, Calderdale is a largely rural district with a sort of urban conurbation at one end, and sort of 13, 14, 15 miles away at the other end, there are still people who are experiencing multiple disadvantage but have a real challenge to get to services to seek the support that they need. I should say that when you get the slide pack, there's quite extensive notes in this. But just looking at the graph on the screen now, these are what's represented there in green are the number of people who tell us that without a navigator service that they have a good experience in terms of accessing mental health services, and that's where the big arrow is at the bottom. The remaining just over 80% have a poor or very poor experience. With a navigator, that experience has improved quite a lot, and this is a survey sample of all our beneficiaries, so probably about a quarter of all our beneficiaries have been sampled in this. But it shows just how it illustrates one of Rachel's earlier points, that without support, it's very difficult to access services. And I think our experience has been that the improvement in accessing services has largely been as a result of workers, professionals in both Wi-Fi and in mental health services, having good professional relationships and good professional conversations, and understanding the importance of the work for both services points of view. Very early on in my experience in Wi-Fi, we had a discussion with mental health outreach team, who told us that they would operate a three opportunities, and then you're off the register kind of approach to people. If they didn't turn up the 3 appointments in a row, then they would stop contacting them. And where we said to the community outreach team, can you tell us all those people that you've stopped contacting, because they're probably the people that we need to work with, because the reason they're not coming is not because they don't want you or they don't need you. So they've probably not had those contacts, and they probably or they're so chaotic in their lives that they can't organise to attend. So to come to the project setup itself in Calderdale, so in each of the 5 districts, Wi-Fi works by running kind of a local delivery team and a local connection, local multi-agency review board, which is for partnership working, and we have local groups of people with lived experience who help inform what we do. And we gathered the lived experience from user groups and beneficiaries to identify the problems they had in accessing services. and we took that to the locality group, which is made up of public agencies and third sector services, to talk about the issue and to see how we could take it forward. And we kind of came up with two models, which were about getting an existing service user-led group to support people to access mental health services, or to resource some additional service in the current kind of mainstream mental health framework, to include Wi-Fi beneficiaries. And neither of these really came to work because we couldn't. There was an unwillingness on the part of the service user-led group to kind of take on people in a self-help kind of capacity who were very chaotic and had quite significant emotional and mental well-being issues, and that the resource was inadequate to kind of bolt something onto an existing mainstream provision. So we then worked. The next step was to try and find a provider who would work with us directly, and we worked with Insight Healthcare, who are a not-for-profit organisation delivering mental health services in Calderdale. This is kind of slightly slow connection, which means I'm jumping a bit. But a discussion with them and a kind of dialogue with them through that we were able to kind of understand, taking what Rachel said about a sort of a psychologically informed approach to the problem. We were able to develop a process by which we could support people to get to do kind of three main things. We would be able to provide people with an assessment of their mental health needs, and either provide or support them to access treatment, and that we would also work with Insight Healthcare to provide training and support to the navigator team, so that they were more they were better equipped to both work with individuals and also work with other mental health professionals, which was really critical. I think that even if they had in the past, even if navigators had been able to get mental health someone to an assessment with a mental health professional, the issue of co-occurring substance misuse and mental illness prevented them from kind of proceeding beyond the assessment stage. So we were able to work in partnership with Insight. We were able to have rapid access to get them to meet the beneficiary quickly and to take them into treatment quickly. Delays in accessing treatment and assessment are often cited as a problem. One of the reasons why beneficiaries have ups and downs in their mental well-being, and it's certainly one of the major causes of their downs. And although we kind of set targets of percentages of recovery rates and measured assessments and contacts and so on, it was sort of implicitly understood that this would be a slightly more organic process. And to be fair, over the year in which we ran the project, we had I think we had 3 or 4 different mental health professionals from Insight Healthcare working with us, and they did things slightly differently according to their kind of personal take on how things are. I think that's pretty much how Fulfilling Lives works anyway. But we had the best results we had where the professionals were happy to co-locate with a navigator team, work flexibly with the navigator team, and go out to meet beneficiaries in their own homes or in neutral spaces, where the co-location, that navigator team had very much an open door policy for beneficiaries. It was part of another service, so people who were beneficiaries would call into their office, and having the psychologist working in the office meant that they were able to introduce themselves or break off from what they were doing and see a beneficiary, and that kind of the immediacy of that was really critical. So one of the watchwords really of all this has been that working with our client group, that the key thing is engaging them, not forcing them into compliance with a kind of a systematized approach. So on the screen now, you can see the kind of the findings that we were, co-location, like I've just described, reducing cancellations and non-attendance by working with people. Part of the Fulfilling Lives and the navigator approach is to work on a kind of individualized support plans, and working with the beneficiaries' engagement at the point at which they want to undertake a piece of work. Then that's what drives their overall support plan. But I think, again, one of the kind of misunderstandings that we had when talking with mental health services that we kind of came up against early on was that we kind of thought that we had to deal with people's chronic and enduring diagnosable conditions. And actually what Insight taught us was that what's really important on a kind of is about day-to-day tactics and techniques, using CBT, using eye movement reduction therapy and counselling, just to get people into a better place to manage their substance misuse and reduce it, to feel confident enough to attend assessments and so on, and appointments. And actually, what emerged sort of during the life about people with multiple and complex needs often having pre-existing traumatic experiences that they're then self-medicating to resolve, hadn't really kind of hit us until partway through the life of Wi-Fi. But there's certainly some unaddressed trauma, then a period of self-medication, and then another period of mental ill health that was a kind of consequence of self-medication. And that we weren't going to be able to get back to, it wasn't really our job to get back to that original trauma stuff. Resolving that wasn't our area of expertise. That I think that where we could do the best work was in getting people stable and getting people in a position where at some time in the future, if they so wished, they would be able to address that deeper trauma. So the principle of the project was that Insight Healthcare would work with, assess everybody who was on our navigator caseload at that in the period of their work in that year. So there was 35 beneficiaries we were working with in Calderdale at that time. And some of the the figures are up in front of you. I mean, we had better than expected DNA rates and better than expected attendance rates. Just over half, just under half, sorry, met the definition of recovery in those terms. But I think it's also worth noting that from what we've seen elsewhere in our beneficiary journeys is that even if people don't meet the success as defined by a service, that by and large most beneficiaries make some improvements from where they were, and you have to bear in mind that people are starting from a long way back. I mean, in terms of for people with mental health condition, however they define that, their substance use is of a level where they're having to use substances every day simply to cope. They're at the most significant level of substance use. So almost all beneficiaries end up somewhere better than where they started from. I think that it's worth noticing that people relocate, people go to prison, people die while they're on the project. I mean, the morbidity, the age of morbidity is extremely low for our beneficiaries anyway. But it just goes to point out that actually they're not in control. You know, mainstream mental health services are perhaps designed for people who are who can maintain appointments regularly, who can self-manage and take what goes on in the therapy into their daily life and make improvements and grow in resilience. For our beneficiaries, quite a lot of things happen to them that are beyond their control, and that needs to be factored in when you're measuring success. Sorry, I was shot in the slide again. So we evaluated it. We did a co-evaluation with people with lived experience, who undertook interviews with the people beneficiaries who use the service. And I think that range of experiences again reflects some of the things that Rachel had said, and also some of those that some of the things that we've previously identified, that some had begun treatment and discharged, some had been excluded because they were ineligible. This approach was more person-centred, offered a range of therapies and locations, and was coordinated with the rest of their care. That's absolutely critical. This doesn't happen enough. And at the bottom of this slide, you can see some of the specific areas of assessment that we use, where people, showed where there was consistent benefit, there's consistent improvement shown across the beneficiaries. This is yeah, we're coming to the end now. Yeah. Okay. Okay. Well, the remainder of the slides will be in the pack, as I said, including a mini case study, which helps. I think this slide about outcomes and exits confirms again what Rachel said, and finally the kind of what we've learned is probably the best slide to leave you with. We were told that it would be really hard to work with this group. It's not, but it requires you to redesign and rethink what you're doing. I've mentioned the different levels of work. joint work and multi-agency working is critical, and it's people's for this group, people are entitled to, entitled to a service, entitled to a service. It's about making the service work for them. Okay, thank you very much.
Brill, thank you, Mark, and sorry to have interrupted you there. I'm just conscious of the time.
No, yeah.
If it's all right with you, I'm going to ask if people have questions for Mark, could you just pop them in the chat box and I'll kind of come to them as we go along and also come back to you at the end of the webinar.
I'll come back to the end.
Hand over now to Bruno and Andy, who are our next speakers, so bear with me whilst I just get their slides up. Sorry, gents, I am coming to you, just finding you on the list of attendees. So Bruno, you now have control of the slides and I've unmuted you, and Andy, I'm coming to you now. Over to you, gents.
Right, good morning everyone. My name's Andy Meakin and I've been the Programme Director of Voices for the last 6 years. Before that I worked in service contract management and commissioning for 15 years in various sectors. Hand over to Bruno.
Yeah, morning everyone. My name is Bruno Ornelas. I'm the Head of Service and Safeguarding Voices, as well as Bright Futures Housing Association. Like Andy, I've been working at Voices since the very beginning, which is about 6 years ago now.
Great. We'll just kick off with the first slide then. So Rachel covered some of this earlier. Voices is one of the Fulfilling Lives projects. We've got kind of 3 aspects to what we do. One is a direct delivery aspect. Another is a learning and workforce development programme, which has delivered a service to around about 3,000 people, places on courses locally. And we also work very closely with people with lived experience in the form of expert citizens. So far, we are on our way to having worked with around 400 people with multiple needs in Stoke-on-Trent. And we're also identifying opportunities for systems change. And one of the areas that we've looked at is the opportunities afforded by the CARE Act, which came in earlier on in the programme, and looking at whether our assessment was that it would provide better access for our customer group, and so we set out to test that with the toolkit. So what we hope to answer in this webinar is, what is the toolkit, why is it needed, who is it for, and how is it used?
Thanks, Andy. So first of all, just to start off, is looking at what were the most common responses we were receiving, in particular from adult social services, when we were submitting referrals for social care assessments. So this is going back to 2015, when we first started engaging with that part of the system. And here's a list of things that we commonly heard, which I'm sure if you take time to look through them, you'll see that they're probably not too dissimilar to some of your own experiences, particularly if you're a practitioner or a manager of services. And to this day, we still, and again, this is not just Stoke-on-Trent, still hear some of these things occurring. So in relation to people being denied assessments because they have mental capacity, or because even before an assessment's taken place, a decision has been made that they won't meet the criteria. So all of these sorts of things that are listed here were not in keeping with the CARE Act, its duties and its powers. I know some of that has changed given the Coronavirus Act. If we've got some time, we can go over that in the questions. But for now, these are just a list of the things that we often heard. And in particular, the one that was quite common and quite difficult to sort of challenge, or we weren't too sure of the sorts of things we could say that would be in keeping with the Care Act, was when social services were saying they didn't have care and support needs, or people with multiple disadvantages did not have care and support needs. So this was also an opportunity for us to have a good look at the types and the quality of the referrals that we were sending to social services. So this was not to be too self-critical, but it did encourage us to self-reflect on the sorts of things that we were submitting to see if we were going to interact with this part of the system. We of course needed to understand how it was that we were putting the case across. What we realised early on was that we had a tendency to narrate an EastEnders storyline to construct needs. So we were very, very elaborate about people's circumstances and situations, which, although relevant, was not necessarily entirely altogether relevant for the purposes of a social care assessment. And that often, in making a referral, would make requests for services or intensive support. So we would be asking for things to meet people's needs rather than having gone through the initial process of identifying what the need actually is in the beginning. And we were often making referrals in order to secure services, which was not the point. The point was to secure an assessment in the first instance. And social services sometimes perceived our referrals, and this was more on their side than on ours, as a handoff. So we'd make the referral and then we would go away. So we needed to clearly state early on that this was the beginning of a journey and that we'd be sticking with the person as well as with social services, so that we could have joint assessments, which is entirely possible under the Care Act. It made us reflect on whether we were doing too much and masking need. Now, I know this is it can be quite a bit of a controversial area, but what I meant by this was the things that we were doing because the person was unable to do it themselves, were we clearly on the assessment, so for example, we could be saying, we need to do X, Y, and Z, because if we don't, the person won't be able to do it themselves. We weren't always clearly stating that. And sometimes the Care Act came into force, gave people an opportunity to have an assessment, which was a duty, irrespective of who they were or how they presented. And sorry, I can just hear some background noise. I don't know if everyone can hear me okay. Yep. So it just gave us the opportunity to look at how many cases we were actually referring, and just because the legislation said that anyone with appearance of need is entitled to an assessment doesn't necessarily mean you have to refer everybody at one go. And then again, we're expecting a quick turnaround, and that has to do sometimes, in particular if you work in multiple disadvantage or in the homelessness sector, we're used to dealing with things to do mainly with housing, so priority needs statuses, which suggests more of an urgency. But in a social care sense, that urgency that we would often find with housing is often not the same sort of urgency required in the Care Act, although there are provisions under the Care Act that would allow us to meet urgent need if necessary. And then not all focus to social care, and then sometimes there was often an uncertainty whether the case was actually for a social care assessment or for a Section 42 inquiry, which is a safeguarding referral. So it's over to you, Andy. You go to the next slide.
Thanks, Bruno. What we noticed was that we didn't appear, when we were making referrals through the Care Act, to be speaking the same language as our colleagues in social care. And so when the referrals were initially rejected, we were surprised. And so our first thing was to look at what it was that we were doing, and what was our influence on that as an outcome. And so what we were hoping to do was to create a Rosetta Stone that would help to kind of interpret the language, and that required us to look in detail as to what was and wasn't eligible under the terms of the Care Act, and to understand, therefore, what social workers conducting assessments were looking for, both in terms of deciding whether somebody had an appearance of need and therefore was eligible for an assessment, but then also what those needs were. What was it that ticks the right boxes for people? So we did some work to have a look at the eligibility regulations in the Care Act and compare those to what we were seeing with our customers in terms of multiple disadvantage. And we began the process then of creating a tool to understand how we could navigate those difficult conversations with social care to help them see the multiple needs customer group in the context of the Care Act, in order to overcome some of these narratives, particularly around lifestyle choices. So, you know, an example would be there's a higher incidence and prevalence of cognitive dysfunction through acquired brain injury in the customer group. And the symptoms of that and the presentations of that can often be mistaken as behaviours and tried to be explained away as narratives of non-engagement. And so what we needed to do was to come up with a way of setting people's needs in context. You know, a key to that was the involvement of people with lived experience, the individual themselves, the support worker and the social care in this kind of three-way conversation. And what the tool does is provide a format in which to help people through their thinking while they describe people's needs in the context of the Care Act. So that was helping to overcome this EastEnders storyline. And an example was we had a customer who was, you know, walking out into traffic and displaying all kinds of bizarre behaviours. And our original conversations with social care were pointing us in the direction of community safety and a policing stroke enforcement response, rather than seeing the person's behaviour in the context of a social care stroke mental health need. And we needed to be able to explain that person's presentation in a way and their behaviours in a way that focused on their ability to maintain their own well-being, to overcome this narrative about choice. And also their ability to achieve a different outcome and the potential for people's needs to fluctuate on a day-to-day basis. And the key to that was the eligibility outcomes set out in the Act.
Thanks, Andy. So that previous slide was that picture on the previous slide showing you what the Care Act toolkit currently looks like. So I'll encourage you all, in particular practitioners are out there who are looking to make social care referrals, and that's even in the current climate with the Coronavirus Act, to download it and have a look at it. It's an editable PDF, so it's in PDF format, but you can type directly into it. It's a 23-page document, and in completing the document, it's not something you necessarily have to submit to social services, but it could just act as an aid memoir, as a training manual for yourselves, if you like. So it's certainly worth going through each section and doing as much as you can of it. So these next three slides are just going to focus on a bit about the eligibility criteria. So these are the sorts of things that the Care Act should be doing, or the people enforcing the Care Act should be doing, should I say. And it's very much a formula. So this is links to Section 9 of the Care Act, which is to do with the care assessment process itself. So what the social services should be doing in terms of its first assessment is understanding whether somebody's needs result from a physical or mental illness or an illness of any other kind, which could include a substance misuse problem. And a formal diagnosis is not required. So if you were to ever hear, well, there's no mental health diagnosis, therefore we can't proceed, that would be incorrect, and that's open to challenge, so please do go ahead and do that. So that's the first step, is does the person's needs result from a physical or mental impairment? And in the context of people with multiple disadvantage, the answer to that is probably yes. So that's the first step. The second step is, because of that physical or mental impairment or substance misuse, they're unable to achieve at least two of 10 specified outcomes. So the Care Act has 10 outcomes. What you have to do is understand whether, because of the first step, the physical or mental impairment, they're unable to achieve 10 outcomes. And what I've laid out here are 4 of those outcomes, which seem to be more relevant for people people experiencing multiple disadvantage. So that links to things like maintaining a habitable home environment, developing and maintaining family or other personal relationships, accessing and engaging in work, education, training and employment, and making use of necessary services and facilities in the local community. If you to understand multiple needs, in particular in this last bullet point, as people's ability to engage in processes, now is that ability or inability to engage, where does that stem from? And this would be an area that would be worth exploring. So that's step 2, and step 3 is, as a consequence of having a physical or mental impairment and being unable to achieve at least 2 of the 10 outcomes, there is likely to be a significant impact on the adult's well-being. Now, significant impact is not defined in legislation or in the statutory guidance at all. It's supposed to have its everyday meaning. But what the Care Act does provide is a list of well-being areas, which we'll look at in a bit. But just expanding on the 10 outcomes, so there's the list of the outcomes that people are assessed when conducting Section 9 care assessment. So remembering that you have to try and evidence people's inability to achieve, and that green box on the right-hand side provides a bit of a scale for you. And this is all laid out in the toolkit. So if you look at the toolkit, this is all laid out for you, so it would be a lot easier for you to match this formula that we're going through. So it looks at people, if they're unable to achieve assistance whatsoever. So, for example, somebody might not be able to make use of their home safely, and then unable to do that without assistance. So that's the sort of things that you need to be recording. But people could be able to achieve stuff without assistance, but it just take them significantly longer than normal would be expected. So hence, it's certainly worth going through the toolkit. So once you've identified whether their need comes from a physical or mental impairment and what they're able or unable to achieve against these outcomes, you need to then articulate what the impact on their well-being is. Now, rather helpfully, the Care Act also defines well-being, and there's 9 different well-being areas. I think in the context of the Coronavirus Act, which has downgraded a lot of the duties under the Care Act to powers, the well-being principle will perhaps become even more important than it ever was. So these are the sorts of things that you need to be articulating. So as a result of not being able to achieve one of these or 2 of the specified outcomes, the impact of well-being it could be their personal dignity, their physical and mental health, protection from abuse and neglect, and remembering that well-being can have a domino effect. So if personal dignity is affected, then subsequently their physical or mental health can also be impacted upon. So that's a very top tour of what the eligibility criteria, the assessment process is in terms of the Care Act. And the Care Act toolkit lays this all out for you. And on the margins of each page, you'll see what the statutory guidance and the best practice guidance is. So it'll give you tips on the sorts of things you can include when completing the document. Back over to you, Andy.
Okay, so in summary, really, the messages to take away is that less is more. Be succinct and focus on people's needs, not their behaviours, unless they're relevant in some way. Eligibility is determined following the assessment, and it isn't our job in making a referral to identify the need. it's about the ability to achieve and the impact of that on their well-being, as Bruno was just talking about. One of the outcomes for us has been a improving relationship with our colleagues in social care, because we're making fewer referrals, but they're of a better quality and they're more likely to lead to an assessment and then more likely to lead to a package of support to meet need. It helps to know the process from start to finish and where you're at in each of those cases. Don't be afraid to ask for a copy of an assessment if people are claiming that one has taken place. You can ask for the social worker or a registered professional, rather than some social care services have a kind of a triage, which they're not social workers or registered professionals. Make it clear that your intention is to remain involved and to contribute to any assessment with relevant information, and even potentially to kind of help to broker the services that are needed if that's identified. And, you know, presenting us as being part of that whole team, and that we're in it for the long term with our colleagues in social care. And I think it's important to re-emphasise the point that Bruno made earlier about the toolkit not necessarily being something that's completed verbatim every time. It's an aid memoir or a reminder. We certainly don't complete it very often anymore. It's more an aid to the conversation. If we are completing it and sending it to social care, it's likely that we are doing so because we're in some level of disagreement about the outcome so far. So that's it. Thank you for listening.
Thank you.
Brill, thanks Andy and Bruno. That was great to get an overview of kind of the development and application of the toolkit, so thank you for that. If anyone has any questions, then please do either unmute your microphones now or pop them in the chat box. And I ask, if not, keep your microphones muted just so the sound quality retains. You did mention something around kind of the impact of coronavirus then on the toolkit. I just wondered if you could expand on that a little bit and tell us about kind of what implication that might have.
Yes, I'm just on mute. Okay, so the people probably be aware that emergency legislation got passed last week, and that's essentially, in terms of as far as the care Act is concerned, it's downgraded a lot of its duties. So Section 9, the assessment that we've been talking about, has always been a duty under the Care Act, so that's the duty to assess. So it was never an option whether social services should assess or not. However, what's occurring now following the coronavirus is it's downgraded that power, which means that local authorities will have the discretion or an option as to whether they exercise that power or not. But even having said that, even if a particular duty is downgraded to a power, it's still liable to specific legal requirements. So, and there would have to be a good case for the social services not to assess somebody. So I know at the moment there's lots of questions being asked around what would this mean. We're currently having more of an in-depth look at the possible impact of the Coronavirus Act, the Care Act, and the work that we've been doing with the Care Act alongside people with multiple disadvantage. However, you know, and then in the Coronavirus Act is making more reference to meeting urgent need as well. So there would still be a duty to meet urgent need, providing that there's likely to be an imminent breach on somebody's human rights. And in the context of people, again, on a case-by-case basis, but just speaking generally, people experiencing multiple disadvantage, you know, I think there's often a good case to argue, should the evidence suggest that, for human rights breaches as well. So there's potentially another avenue in which to add weight to advocacy. But it also makes the Care Act toolkit even more important to look at. as well, especially looking at the well-being area, how those areas get impacted. Yep.
Yeah, definitely. Thank you for that. I am conscious of time and that we've run over a little bit, so I'm going to kind of wrap things up now. So I'd like to thank all of this morning's speakers, so to Rachel, Mark, Andy and Bruno for your presentations. If people do have questions or comments after today, then we will share the slides, so their kind of contact details will be on there, so you can contact them directly if you wish to. So to keep up to date with us moving forward in the national evaluation, please, or any other learning events and opportunities too, please do follow us on Twitter or sign up to our national evaluation newsletter, and that's quarterly. So all that remains from myself is to say thanks for joining us. Have a lovely afternoon. Take care of yourselves and keep yourselves safe and healthy. Thank you.